Get started, you think?
We're going live. Yeah, we're live.
Live, okay. And I think we have some folks on the phone as well. I just heard beep. Well, let me call this meeting to order at 10 o'clock on July 7th. This is the Assembly Health Policy Committee. And why don't we start with a roll call?
Okay, Mr. Presredia?
Here.
Ms. Oliphant? Ms. Allard? Ms. LaFrance? Mr. Constant? Ms. Quinn Davidson? Mr. Dunbar?
Here.
And Mr. Rivera?
Present.
Thank you.
Is there?
Sounds like somebody is on the phone. Is there someone on the phone from the Assembly joining us?
That's good. Is that what that red
We're
line
not
means?
muted, but the participant is muted.
Okay. All right. Well, first, I guess I want to just say hi. I'm Cameron. I'm newly chairing this committee, and Ms. Alatel will be vice chair. And today, I think what we wanted to do is just start out with getting an update from the division of directors, and also getting a chance to meet the new director. Also, I really was hoping to hear not only an update, but any information about what the focus should be for this committee over the next year. And I think that's part of the conversation. For those of you who've been more involved in this committee than I have, I'd love to hear if there are ideas or priorities that are out there. So why don't we just get started and have our updates from the division directors who would like to begin.
Let's just all come up there.
I think that's the best way to do it. Come on up.
Sit on there a little bit.
I'm sorry. Thank you very much. Want to make a clarification for the record. I said director, but I mean acting director until you're confirmed. So, all right, great. So maybe an update. You guys have an update prepared for the meeting?
Sure. Do we want to start with the introduction maybe first?
That would be nice.
Introduce, started that in.
Yeah.
Okay.
Yeah.
I'm Christy Lawton. I'm one of the division managers, so not
Okay.
division director, just
Oh,
one of the
division.
division managers.
Gotcha. Thank you.
And oversee the public health division. So it's nice to be with you guys today.
I'm Janet Johnston, I'm the epidemiologist.
My name is Nicole Lebo, and I'm the human services division manager. And it says division directors
Yes,
on lots
we will
of
change
public
it.
papers,
It's-
like all of our routing slips, and like it says it. So
Does it?
it's not you that's the only one.
Including me, when I said I'm
Yeah.
the first group. I'm Dave Morgan, I'm the acting director of the Anchorage Health Department. And the three of us, plus a couple of other supervisors, managers, have been meeting probably, we've met about 80 hours or something, it seems like that.
100.
But we spend 2/3 of the day basically going through all the programs, the relationships, metrics, where we are, and where we plan to be, and making sure that everything is as seamless and processes are going forward, no matter what changes in leadership has been. And I'm treating this as a management team, and we meet, work together, and process what we're going to do and how we're going to do it. One person is out on vacation.
Yes. Deputy Director Deanne Petco,
Is out for a few days.
who's just about to celebrate her 25 years within the health department. So we'll invite you guys for some of her
And
celebrations.
what I asked them to do was sort of prepare what they would normally send to Heather and her, that she provides in her report, but to bring it themselves this time, number one, so we could get accustomed and get used to that. But we have so much stuff going on that it's on day 4 of my arrival. There's no way to give justice to the process. All I can say is, in comparing all the metrics, and there's 13 pages of them, basically, comparing it to the state averages in all those areas, the municipality of Anchorage is above the state average and doing better than the state on the percentage, whether it's vaccinations or other metrics. So basically, we're pulling the rest of the state. I dare say that. There's a few small boroughs that do a little bit better, but that's not that tough when everybody lives in one or two towns in the entire borough. So enough said. Would you like for them just to start at that end and work their way?
Yeah, I mean, I think we have probably some specific questions, but I'd rather hear the updates first, and then we can ask questions following that.
Okay, sure. I'll start. So I've got just some things I wanted to share that are a little bit update and a little bit just along the lines of how the assembly might be able to, this committee might be able to assist with some of the efforts in public health. As you guys know, much of my team in the public health division, which comprises the community health nursing program, which is essentially all of our clinical services, as well as WIC and SNAP Ed, and then our environmental health program. Much of those folks have been actively and fully engaged as a part of the COVID response over the last year and a half, and in the last few months have been getting back to really fully engaging. One of the successes and updates that I just would be remiss if I didn't share is just the amazing undertaking that they have really went through this last year and a half, creating things from scratch, which really started as a pencil and paper endeavor in our conference room. Before we had a database and all the things we have now, and contractors helping with vaccine at a really large scale. But through that, we continue to offer and maintain a core amount of essential public health services that were being offered in our disease prevention and intervention unit. So continuing to serve our tuberculosis cases, continuing to serve folks in our reproductive health clinic that had STDs and other needs that really can't be met elsewhere. Our environmental health team also moved to providing all of their services for the businesses that were able to stay open electronically so that there wouldn't be a disruption for them or a delay. So there's been just amazing work, as well as WIC, that's been provided remotely, and continues to do that through a federal waiver, at least for a little while longer. With that, though, there are a number of challenges, and I wanted to just mention a few specific to, really, I think it's most striking in my division, but I think it's likely a widespread municipal problem of pay scales that have not been kept current to be able to really successfully recruit and retain qualified candidates. Most striking is the nursing salaries that we offer for registered nurses is far well below every other employer in town. We recently did a study of that, and HR really helped us analyze that. And thankfully, with support from the Assembly, we were given some additional funding so we could raise the salaries for our nurse supervisors, which have largely been vacant for the last year because I can't recruit anybody for those jobs because they're so low paying. And I'm happy to report with that increase in salary, we have all of those positions filled today. And I think it really does represent what's needed to happen now with also the RNs, the PHNs, because we turn them over faster than we can even train them, which then means we can't continue to deliver the level of services to the community in the widespread ways that we really need to be, because we simply don't have the body. So that is a huge thing. And I know that Ron Kamahali and, well, I think the director's not there anymore, but Ron out at HR has lots of information he can share, but anything you guys can do to help us look at that. And we also have the same issue with incredibly low pay in our WIC program, primarily with our folks that do our customer service and front desk. They're called Family Service Associates, and I think they are range 9. And so the minute they're hired, as you would be if you're a young professional, which most of them are young, starting in their career, they're looking for other jobs. And again, the inability to retain them and not having a decent wage that directly impacts our ability to serve vulnerable at-risk families who are in need of those benefits. So that's a big one I wanted to mention. The other thing I wanted to add is just that also I think it's important that the committee could really help us with, that has become, it was striking at the time the pandemic happened, but it's also striking that now that we're slowly starting to move into a recovery phase, that there is still such a lack of understanding about what the Anchorage Health Department does and the role we play in the community. It really directly impacts, I think, that lack of visibility and awareness at all levels, really, even within the municipal government and with some assembly members and just the general committee. It really hampers our ability to make forward progress and to get the kind of support as we think about moving into a Public Health 3.0, which is really kind of a model that we have been trying to get into that space, which many local health departments across the country have already transitioned, but it really requires the health department to be having adequate resources, leadership, data capabilities so that we can really cross-collaborate and engage in relationships with private and nonprofit public sector entities to really be ready for the next public health emergency and to continue to make progress on all the ones that we're currently facing. So I don't know how long I've been talking at this point, but it feels like a while.
And
So
I'll pause you
pause
for a
there.
second,
Okay.
and just for the record, we've been joined by Mr. Weddleton, Mr. Constant, and Ms. LaFrance.
Perfect. Those were the things I'm happy that you gave us the opportunity to talk about things, how you can help. Those are probably the biggest issues. As you guys, I'm sure, keep up on the news, TB continues to be on the rise. Also syphilis, which has doubled in the last year, is a huge concern. It's also sadly been infecting more infants, and so that's been a dramatic increase in congenital syphilis, and that is going to require an all hands on deck approach and close collaboration with the state and other health providers. And these are the kinds of things that, while staffing and retention of nurses and clinical staff isn't the only factor that limits our ability to make progress on some of these important issues that, Anchorage and much of Alaska can't ever seem to make the kind of momentum forward to really improve those rates. It certainly is a driver and directly impacts our ability. So I think I'll stop there, and if there's any questions or.
I would just want to add on, and I think to put a finer point on the turnover, I do believe that the health department has the highest turnover rate within all departments within the municipality. And I would agree with Christy that this is because of the pay scales, and often that's because we're getting grant funds and we're not seeing any additional contributions from the municipality, and whether that's like to change someone's pay scale from $12 an hour to $15 an hour, by that extra contribution and or adding on additional staff positions to do the extra work that's then distributed amongst people who are underpaid and overworked. I would say those are all contributing factors. Yeah.
And it looks like I have Mr. Rivera and then Mr. Weddleton. Before I have them ask their questions, you mentioned Public Health 3.0. I've heard that a couple of times. If there is a resource that you have that you could forward to me, I'd really love to become more familiar with that so that I'm up to speed.
I'd be happy to do that.
Thanks. Mr. Rivera, I think you were next.
Great, thank you, Mr. Chair. One of my points was also on Public Health 3.0, and I think it would be helpful just for this committee to get a better understanding of what that is and what that looks like. But going on your point about salaries, particularly as this administration implements a hiring freeze, or as I've heard it called, a pause for an unknown amount of time, I think it's particularly important that we keep our employees if we're not going to be hiring new employees. So this is also the second time in as many days that I've heard concerns from higher level employees in different departments about keeping folks and salaries, and the need to ensure that we have both salaries and other ways of enticing folks to stay in the municipality. So it seems to me like this is a municipal-wide issue. So I think it would be, I don't know if it's necessarily something that this committee could certainly delve into it when it comes into the health department, but I think it's something worth looking at it a more holistic way, and I don't know exactly how we do that. But that's, I think, a conversation worth having. Thank you.
Thank you, Mr. Weldon. Or you do want to respond?
Yeah, this is actually not that uncommon in health, where you have a department or a hospital or a clinic that stays static for 3 or 4 years. The standard going rate, because for some reason, I still get a lot of requests from my other, my career, that the average advanced nurse practitioner or an RN with some experience in this, there's not an even Providence, ANC, and the Anchorage Neighborhood Health is having a great difficult time filling nursing, pharmacy, and dental. I know this sounds weird, dental positions, because dental practices. And those need to be looked at standard-wise at least every 24 months to make sure you're keeping up. I know that we have some positions that are empty, and I have already started some discussions in it today at 4 o'clock. I'm going to bring that up at the director's meeting. Because you can't do it. It's like playing baseball. If you don't have these positions filled in the health department, then you can't do public health. This is a hands-on, as you well know, a hands-on operation. So that was my, other than some job positions that were kind of hung up that over the last few weeks, and another down at, I guess, HR somewhere, which I went down and got those moved off a desk and signed so they could fill them. These are jobs paid by grants and do work, and in a CDC grant, if I'm not mistaken. So that's what I've spent most of my time doing, things like that, and listening to what they're doing, to the point that I think a lot of them are just getting tired of me asking questions. So I didn't mean to interrupt.
No, thanks. And thanks for your response. Mr. Weldon, your question.
Yeah, so following up on that, I might have missed something. So do grants specify an amount that would be paid, and then you would expect the city to augment?
No.
So I might have misunderstood.
No, I'm sorry. What I was talking about is you would have some positions and some grant. We had some positions and some grants that were via CDC type stuff. And in that situation, that was an internal problem to the city, where some stuff got jammed up in HR. It's been down there 6-8 weeks. On top of everybody is recruiting and trying to, I guess I'll use the unpolite term, steal our nurses and steal our professionals. And so it's a twofold problem. So I've kind of was able to shake loose getting stuff out and processed. The next one is, like I said, I'm going to talk to the city manager and the mayor and whoever, O&B, and get them the study that you'll get, I'm sure, and talk about this, because, again, as all of you know, if we don't have dentists and doctors and nurses and pharmacists, you can't deliver public health. And our business is public health. You know, I mean, we got to have people there. And they, honestly, they are blue. I know of a nurse, an advanced nurse practitioner, that was recruited by a hospital in Seattle from Providence because she lives next door. And not only did she add, this is going to Seattle, 25% more to her salary, they totally paid for her moving. And a bonus just to sign up. that's what they're going up against to keep their nursing staff. I haven't heard if they've gone after any other paraprofessionals, but nurses are worth their weight in gold. Is that a good term? Okay. I was almost going to say silver, but let's use gold.
Okay, I was actually going back about 5 minutes ago, I think, to a question, but she has to live in Seattle, so that's a downside to ship here. So I think, and you, I'm gonna say, you're,
Nicole, leave
oh,
out.
I think so.
That's okay.
COVID, I don't remember anybody.
Hey, look my chin.
Drop. So I think you had said that, like, grants to that university and not augmented by the city.
Right, so for example, I mean, I don't want to speak to the WIC grant, because that's not my grant, but childcare licensing, which is a program in my division, the state grant pays 99.1% of that program. And we add in, I think the money that we add in is for equipment. We don't pay in for additional positions so you just get a set amount. And then we say that's how many people we can hire at whatever step or rates or whatever. And so either adding additional whole staff to increase people's ability to like spread out the workload or having the state grant maybe pay for 75% of one person's salary, and then we would pay for 25% of their salary because we say that that's a valuable program above and beyond our ability to have it funded by the state. It's also important to the municipality, and we know that because we're paying for it.
Yeah. So, pay is one thing, but, city benefits are real good.
Yeah.
These normal private sector, do staff value that, the level it costs us?
I mean, I could only speculate at this moment. But I agree with you. I appreciate my benefits.
Thanks.
I'm assuming that we have an interview when someone leaves. Most places I've worked at, you got like a little, why are you leaving? What's up? And probably I'll see if I can get a summary of those exit interviews. We do exit.
We do.
Okay. And so I'll get a summary of those professionals that they're talking about, put that behind this PACE survey of what is, the base pay, the average pay, the top to low, all that stuff.
Thanks. Next I have Mr. Dunbar and then Mr. Constant.
I have two pretty specific questions. I don't think they're just for the public health division. How do you want to do this, Cam? Do you
So
want us to keep going?
why don't we, if you guys have questions, we will get through those and then I want to get on to the next.
Kind of germane to what we were just talking about.
Yeah, one of my two is, I guess I'll do one of the two and then we'll go, I'll come back to the other one. So during the campaign, Mr. Bronson said he was going to cut every department from between 5 and 8%. So my question is, have you started to do that kind of evaluation? What does a 5 to 8% cut look like for the health department? What are you going to cut?
I honestly, I'm going to say what I'm going to say tonight at 4:00. Maybe can I get a tape? So basically, the health department, which I thought I knew a lot about this health department because I was chairman of the Municipal Health Commission and on it for 6 years. And I thought I knew a lot about it. But when you start really getting into the complexities, the interrelationships, who's doing what are they doing, I personally have not started that process. The first thing I wanted to do is absolutely do no harm. I wanted to keep everything seamless, especially when you have a pandemic, when we have some communicable disease vectors that are increasing, not only here, but all over the United States. And also maintaining vigilance on Delta to make sure that we got that, at least we know what's going on. And these guys have a lot of talents, but telepathy is not one of them. know the battle scene and then react accordingly to a range of forces. So I have not done that yet. I first wanted to shake loose and correct any problems. When you change administration, stuff always, just everything stops on the administrative end. And I'm shaking all that stuff loose so that they can do their jobs that they normally would be doing. And probably over the next couple of weeks, I'll start looking at that process. In my own mind, my mind is open. If I find something that can be cut, of course I'll recommend it. But right now, my main concern is to make sure we deliver public health through these other programs, because they affect a lot of people. And as we found out in the last year and a half, it could really create havoc in the general economy. So, in all honesty, day 4, they could tell you that's what I've been doing, and making sure to attend scheduled meetings, and those that's a bunch of stuff. So probably in the next couple of weeks, if I come up with anything, I'll probably send a copy of it to the chair so he knows where I'm going and what's up. But it's going to take a while, because it's like a big balloon. You push in here, and it just doesn't bulge out here. It bulges in about 14 other spots. So I have to be very careful about what we do and how we do it, because it affects several programs, because we're so integrated, to get economies of scale and to be low cost. You know, there's no silos really. It is interdimensional. I know this sounds kind of strange, but that's why I rely on them. And usually we meet every morning for a while to kind of find out what's going on and what's happening and what we need to get done in the short run, and work on the medium and long range planning. So,
Mr. Dunbar, your question answered?
Yeah.
Yeah, okay, great. We're gonna move on to Mr. Constant. We're gonna try to be brief, because I wanna make sure we get other updates. So
Yeah, mine is very brief. It's more of a statement about the benefits conversation that we previously had. You know, Mr. Wilton, John, you started that the Muni's benefits are great, and it's one of the draws. In fact, that's changed. We don't offer the presenters long-term benefits that previously existed, and now our benefits package is competitive with, but doesn't in any way exceed South Central Foundation, Cookman Tribal Council, Providence, or any of the main healthcare providers in our community. In fact, you can get a better deal there now than you can here, even with the healthcare that's provided by the community. So we aren't any longer in a position that we excel in the benefits that might draw people here.
Thanks. Okay, let's move on. Would you like to go next?
Okay, I'll try to make this brief. This is actually just the COVID update, not anything in operations. So a month ago when I talked to you guys, I was really excited because cases were coming down. Everything was good. I'm not as excited anymore. Cases are going up. Over the past 3 weeks, we've seen week over week increases. We had a really big increase percentage-wise 3 weeks ago, where we had basically a doubling in cases. And then we had a week with about 30% increase. This week looks like about 25% increase. So we went from about 2.5 cases per 100,000 residents as the 14-day average that I think you guys are all familiar with. We're now up, today's number hasn't been updated by the state, but based on my calculations, I expect it to be close to 7.5 per 100,000. And it's really important to keep in mind that we really have 2 subpopulations. About half the population, at least of adults, has been fully vaccinated, and the other half has not. So for people who have been fully vaccinated, we're looking at probably less than 2 cases per 100,000 per day. We still get breakthrough cases. Fortunately, if we get those, they're still less severe, less likely to be hospitalized, and less likely to spread. But for the people who are unvaccinated, we're looking at a 14-day average case count of equivalent to about 12.5 new cases per day per 100,000. So again, the unvaccinated population is going back into that high-risk category. So I'm very concerned about that. We've been holding steady in hospitalizations over the past couple of weeks, but over the past week, that's increasing. And it's always hard to tell with this type of increase as to whether it's just a blip or whether it's going to be a sustained increase. But as of July 5th, we had 21 hospitalized COVID patients. And that's a number that we haven't seen since back in like May. Over the past week, we went from being down around 6 hospitalized COVID patients up to 21. My guess is that both the 6 and the 21 are slight outliers, but we're staying, I think, in the high teens, which again is an increase and a little bit concerning.
I'm gonna pause you for a second. I have a question for Mr. Dunbar.
Oh, yeah, I was wondering if, can't remember if we track this or not, or if you have any data on. So you have the unvaccinated population, you have the vaccinated population. Another distinct population are people who've had COVID in the past. I'm wondering what, if any, reinfection rates we're seeing.
So I can try to take a look at that. We haven't been tracking that.
So I guess people who had COVID in the past have some natural immunity, aren't getting vaccinated. If that group
Right.
is being infected at any significant rate, I'm just curious.
Yeah, unfortunately, the way the state does the tracking of the cases in the NDS system, which is just their tracking system, the reinfected cases, I don't think there's a variable I can easily pull out on that, but I'll take a look. They have just added a vaccine breakthrough variable, so I can pull that out. But we haven't, they also don't post on their dashboards about reinfected. I think part of that is that we can look at confirmed cases, but we also know that there are a lot of unconfirmed cases. And then it gets more complicated now because some people who have been infected have also been vaccinated.
Right.
So you're right, there's all kinds of different groups, and it is a little bit simplistic to just divide it into the vaccinated and the unvaccinated. But that's data that's, very much available. Sure.
And the 2 questions I had, one was, the director mentioned Delta. I'm assuming that's the Delta variant. I would appreciate if you spoke to that in terms of where that's at in our community. And then the second one's around, I had heard that there was an attempt to look at vaccinating children under 12, but that is not going to move forward. I'd love another update on
Well, so
that.
that's certainly moving forward. It's not authorized yet. So there are, both Pfizer and Moderna have clinical trials going on in younger populations. And Pfizer, I think they're hoping to be able to apply for emergency use authorization, I think for the 5 to 12-year-olds, probably in the September-October timeframe. So we're hoping to see, all school-age kids be able to be vaccinated sort of toward the end of the first semester of the school year, probably not before school starts, but before December. And then at least Moderna and probably Pfizer also has trials going on. They're looking at the 2 to 5-year-olds, and they're also looking at 6 months to 2-year-olds. So there's a lot of work going on with the goal of being able to vaccinate all the way down to 6 months. But those younger ones below 5 will probably take at least into 2022. That's a more complicated, because they have to spend a lot more time figuring out what amount of the dose, but they are working on that. In terms of the Delta variant, so most of the data about that comes from the state genomic surveillance reports, which I don't exactly understand why they're supposed to be doing them every week, but they seem to take a long time to get posted. So I checked again this morning, the most recent report is from June 23rd, which of course means they're from cases that were, specimens were collected a few weeks before that. But we are seeing an increase statewide in the Delta variant. The concern about the Delta variant is primarily that it is a lot more transmissible. So it's like 50 to 60% more transmissible than the Alpha variant, which was the UK variant, which we were all worried about because it was so much more transmissible than the original strain. There's also some data to suggest that it may be cause more serious disease, but it's a little hard to tell that at the beginning of a new variant, whether it's just that we're seeing more cases, and so it seems like they're more serious. But it's clearly much more transmissible, much easier to transmit between people. So whereas, originally we talked about 15 minutes within less than 6 feet of somebody, you would be considered a close contact. You need much less interaction between 2 people. So what we're seeing statewide, it's a small number of cases, but it's growing. We're seeing that primarily, and this was as of June 6th, statewide that about 37% of the sequenced cases were the alpha variant, about 20% were gamma, and then probably about another quarter were the delta. I expect we had a report as of this month that would have increased significantly. And they do the reports by the economic region, so they lump Anchorage and Natsu together, but there was a comment in the report that a lot of the delta cases were in the Anchorage area. So it is definitely a big concern. But the good news is that the vaccines are still effective against all three of these variants. Not as effective as against the original strain, but still definitely effective, meaning they prevent a lot of cases, and they prevent primarily hospitalized cases. Having said that, we have had 2 recent hospitalized cases in Anchorage that are vaccine breakthrough cases. They're 2 recent to have been sequenced, but it is a little concerning to me that we had 2 people admitted to the hospital in the past week who are vaccine breakthrough. So clearly something that we have to keep an eye on. Let's see what else do I say. The other thing I think is important to know is we've only had 2 more deaths announced since the last meeting, but that's a little bit of a sort of false sense of security because the state issues with their the state website for some reason also impacts their death certificates and vital statistics. So we typically see we've been staying at the same level on deaths, and then we get like a tranche of 8 new deaths. We haven't had that in a while. That's not necessarily because those deaths haven't occurred, but because they have not been able to complete the death certificate review to add those to the data set. So I'm sure, with the cases coming down into mid-June, the number of deaths has probably also come down, but we're not at that, but it's easy to think, oh, we've had no deaths in the past month. Not quite. So certainly as soon as those are available, we'll keep you posted on that information.
Doc, the other problem I found when I was doing these kind of reports and reporting that data was it's also many of the cases, correct me if I'm wrong, okay, because you're the expert, but many of the cases had comorbidities that go into the hospital. And sometimes it's a bit I think a little complex. In defense of the coroner here, it's a little hard to determine if the death was from the virus or versus they just came out of their immune system was not working very well, say they were very obese or had just come out of the hospice or were in hospice. And maybe they both work together, but see where I'm going with that?
Right.
And then they do the death work, up the stuff, and then they think about it and get tests back, and then sometimes they change. But so in defense of the coroners, it's not that they suddenly found the cases, it's just things change over time while you're going through the process of preparing the medical records from 3 or 4 places. And what was it the coming out of the 3rd time with leukemia or something, plus they get COVID, or was it they were in a horrible accident and they were, the number that I got from the CDC last year, they used the flu vector on asymptomatic when you're computing herd immunity. And they say for every diagnosed case you have, you can take that, multiply it before, and that gives you really a closer idea of how many have had it. A lot of people had it, they just thought it was a bad cold. If you're 22 and really good health, it would seem like a bad cold or a flu.
Right.
They didn't know they had it. And they just did the first study. It'll take 2 years, is what they told me. 2 years. But on the first go around, they came up with 5. That it's running about 5 times to assign, but they're not saying that's the number they're going to use. So it usually takes about 2 years for the for CDC and the committee to say, multiply that number times how many people who we know have had it tested, and then plus how many have been vaccinated or had the first vaccination, whichever one you use. So is that rational?
Yeah, so I'll comment on two things. The first one, we do tend to think that in Alaska, we've stood up a really robust testing program, more robust than a lot of other states. So the general sense among, so the Alaskan epidemiology community is that we're probably have a slightly lower number, but you're absolutely right. We certainly have not detected all of the cases that are out there. Whether it's 5 to 1 or 3 to 1, might be a little bit lower in Alaska, but you're right, we've certainly not detected those. In terms of the deaths, I think you also make a good point. The reason that, I've said that there were only 2 new deaths since the last meeting, although there are probably additional deaths that will be added, is that the state epi tries to be very conservative. Sometimes you've got a death, it's very clear it was a COVID death. That was the only thing going on. A person was perfectly healthy, ended up in the hospital with COVID, died. That's a COVID death. More often, they do need to go back and they try to be very careful. Certainly if you've got a case where somebody is in a car accident, they end up in the emergency room, you test them for COVID, they test positive, but they die of the wounds from the car accident, that is not considered a COVID death. If you've got somebody with heart disease who was, functioning well, got COVID and then died of a heart-related condition, that is likely to be considered a COVID death because that person would not have died in this time period from heart disease if they had not become infected with COVID. And, so I totally agree with you. That's what's going on. And so, let's say 6 weeks from now, they add 8 deaths. That because those were deaths that they needed to adjudicate based on, not just having a COVID test positive, but also what else was going on.
Being an old certified coder about 150 years ago, we're still using, and this is kind of embarrassing, we're still using the ICD-10 coding used for flu with pneumonia for COVID right now. It takes about 2 years for the medical systems to come up with specific and focused coding and information. And I even saw one in February where they found someone, they re-looked at a death in November of 19. And they started really looking, and it was, the cause of death was flu with pneumonia. And then they started looking at some blood samples, and lo and behold, it was COVID-19. They had to add a death a year later after the numbers were done. So
I'm gonna go on to Ms. French. She has a question, and then move on to Ms. Owen to get that.
Thank you, Mr. Chair. And a comment first, thank you, all of you from the Health Department for your tremendous work, not just this year, but in prior years and all that you do, especially given the issues of pay and other challenges. So I had 3 questions, Dr. Johnson. If you could comment first on demographics, especially in terms of hospitalization, if you know of like age and where they're from, if it's primarily Anchorage residents.
Yeah, that I don't have. So the numbers come from different places. So the 21 hospitalized cases comes from the hospital. So that's just a count of beds. And then we have what I call the NBS system, which is used for actually tracking cases, and we can track hospitalizations there. So I can tell you that those 2 breakthrough cases were Anchorage residents because I pulled that out of the NBS system. I can't tell you that how many of the hospitalized cases are, hospital beds are filled with Anchorage people. But I will say that at this point, most of the hospitals around the state have capacity. So We are staying steady at 6 to 7 people in the ICU. And I think, some of those may be transferred in, but in general, there's ICU capacity here and across the state, and there's bed capacity. So I don't think it's like previous times where we were seeing, a lot of people who were being transferred in because the rest of the state didn't have capacity.
Okay, thanks. And then the second question just had to do with the testing and rates and positivity. And then the final question concerns vaccine hesitancy and outreach, and if you've gleaned any new insights from those efforts, and what are the target areas? Thank you, Mr. Chair.
Sure, in terms of testing, testing is down, which we would expect with cases coming down. Test positivity is up, but just a little. We're getting up to about 2% test positive, which is still, a reasonable percentage of positive test results coming back. We have just, as the case counts are going up, we're going back to doing more testing in the assisted living facilities. We've been testing weekly, and then we've gone down to monthly when the cases got really low. And now we're going back up to weekly, and that will impact the total number of tests. So I think we're still doing a good job with testing, but it is very important that we keep that testing available. In terms of vaccine hesitancy, certainly the rate of increase in vaccination coverage is moving up very slowly, maybe about 2% a month, 2.5% a month at this point. At this point, the people who have decided, I want to get vaccinated and I'm going to find a way to do it, have pretty much done it. So now it is more about making vaccine really easily available. I'm thrilled that most of the pharmacies, you can walk in and ask, just get a vaccine. With the Walgreens attending lately, just go back to the pharmacy, tell them I want to get a shot, and they can give it to you. And I think over time, that's going to become the go-to. It's a little harder with providers because they're not giving enough vaccine. They don't really want to open up a vial of 10 doses when they're just going to give one that day. So that's an issue that we're also looking at. But it does seem to be trying to figure out how to get to the younger population right now is my biggest concern. The bulk of our cases are in the 20 to 39-year-old range. They're people, they're out and about, they're working, they're doing things, and they're just spreading disease. So we need to figure out how to get them vaccinated. I'm really hoping that the Chamber's gift certificate program, which is just coming out, will help to appeal to some of those people. I'm also hoping that as parents start thinking about kids going back to school, they'll, get their kids vaccinated if they're 12 and up, and, maybe make it a family affair. So we are, really looking to see what it is that will get people to do it. But it feels like an on-the-ground, almost political campaign right now. And you guys know about going door to door to get people's votes. Or the census, or, getting that last percentage. That's the kind of thing that we're looking at this point. So I don't know if you have anything you want to add on that.
No, I think you covered it.
Okay.
Thank you, Mr. Chair.
If it's okay, I think the doctor has some, don't you have stuff to go?
Yeah, if you don't have any more
Is it
COVID
okay?
questions.
She's got.
Yeah, no,
Thanks.
that's right.
Well, great, and I'll be brief. We have just a few moments here. It's okay. So childcare licensing, I just wanna, if you guys didn't get to make it to the annual picnic, our childcare licensing work group as a group got the Community Service Award, and that was based off of their high level of expertise and technical assistance that they offered to our childcare providers here in town to keep them open throughout this pandemic. And so I just want to celebrate them. And we are just closing out in the next month or so, completing the distribution of $15 million. We worked alongside United Way to get those to licensed centers and facilities, as well as exempt pre-K providers. And so thank you for the support that you guys had offered us in being able to distribute those funds. And at the threat of making much to do about nothing, before COVID happened, the state had come to us and suggested that they were considering taking that grant back from us, the childcare licensing grant. That We are in code delegated to be able to administer that licensing code, but they were feeling at that time that there was, that they could do it within their system more efficiently than we can do it in ours. And what we would suggest is that our providers here in town would not benefit from having the state provide the service. I think the type of service that our providers have become accustomed to and benefit and thrive from is the type that wins awards. And so I would just point that out, that that's maybe a future area of advocacy at the state level that we may need to be seeking your assistance with. So I'll move on to community safety and development, and that is the work group within the municipality that receives and distributes HUD funds. You'll see on the 13th that we have the 2021 action plan in front of you for approval. It was introduced last meeting, and there's an additional public hearing. We've already had public hearings for it as part of our HUD process, and then there's one more through the assembly meeting. So we're looking forward to getting that through. There's a deadline of the middle of August, or else we start to threaten to lose those funds. So we're looking forward to moving that forward. You know, we mentioned the hiring pause. We definitely want to, for this work group in particular, we are losing at the end of the week a fantastic program manager of this group. And so we're gonna wanna not pause because it's highly administrative. There's a lot of regulations, and we need to be pushing all of this work forward, again, or else we threaten to lose some of our HUD funds. This work group also works alongside the Housing and Homeless Services work group that's newly formed. And the Housing and Homeless Services work group has taken on a lot of the COVID funding that's through HUD. And so there are many regulations that a whole new work group is learning, Title VII and all of the HUD regulations, and how to increase our monitoring of those contracts. So like the number one thing that we're doing in our contracts is specifying the type of data that's going to be input into HMIS. In the past, it was like, put the information in. And that was, I mean, like that was the statement. And so now we have spreadsheets. We've been meeting with the provider who sets up, the vendor who works with the coalition to understand what their policies and procedures are so that we can be supporting the coalition to get all of that information. And it's really us, because we have our hands on the purse strings, who are gonna force the providers to be engaging with that system at a different level. And so it just takes a lot of manpower to learn all of those things and then to continue to monitor them. So we have to set them up, and that's what we're in the process of now. And then monthly, we're going to have to be monitoring the effectiveness and the efficiency of providers' ability to change their behaviors. Because up until this point, what we know is the providers have not been in a timely and accurate way putting in all of that information, and we've been, our hands have been tied because we haven't had the information that we've needed. And so that's some of the work that that work group is doing. We're also learning about shelter licensing and what that's going to mean and where that's going to land in a very specific way, and as well as mass care. It's currently not within the health department. There was a conversation with the last administration that we thought that that was that the health department is an appropriate place for mass care, but we also needed to be appropriately resourced to be able to do that work. And it was determined to find another department that was appropriately resourced, which is why it didn't land with the health department, but I'm not sure where it lands at this moment in time, so we're looking forward to what that looks like. Also, just to put it on the record here again, we'll probably talk a lot about this in the Housing and Homeless Subcommittee rather than in this committee, but we have the action plan and then the con plan. The con plan is the consolidated plan, which is basically the equivalent of a 5-year strategic plan for HUD. And so we'll be looking forward to making sure that you guys have a good sense of awareness of what those things are, seeking input, utilizing the right resources, but most likely, and I look to your direction, but, speaking with Assemblymember Zalatel, she felt like that was well positioned within the Housing and Homeless Committee, and then leaving this space here for more public health issues. And then I'll say lastly, the Senior Emergency Outreach Work Group, which has the ADRC, or the Aging and Disability Resource Center. They are continuing to serve their clients, having referrals and person-centered intakes, and getting people qualified for Medicaid and Medicare, as well as just trying to do some outreach. They've been doing some social media campaigns within their own department and now have built up 110,000 followers, and so they're really proud of that. They continue to oversee the Anchorage Safety Center and Safety Patrol contract, and we are seeing consistent numbers from last year at this point in time. The news about that is that we are going to have an RFP coming out in the very near future, and so to possibly find a new provider, to possibly find a different amount than we have paid for that service in the past. And then I understand that the new administration is considering moving that location from where the current location is in the back of the jail to possibly the new location. So those are all things that are sort of up in the air, and we're pausing for a moment in time until we release that RFP, until we find those out. So those are some of the things that we're doing. I've got 1 minute, so someone has a good question, a good juicy one.
If there's no objection, I'd like to extend for 5 minutes, just to make sure we have enough time. Is that okay? All right, great. Mr. Dunbar.
Yeah, actually, you kind of started to touch on it there at the very end. So we've heard from the administration that they plan to put medical detox, they call it, at the new site. And so I was wondering if you could sort of describe the difference between medical detox and moving of that facility into jail, or those are the same things, if they are. If they're not, I'd like to know, is the health department being consulted? And then what does it take to set up a medical detox facility?
We have not had the level of conversation that makes me feel comfortable giving you a full answer, but I think that those are all details that should be fully explored, and then we should be able to brief you on that in the future. That's just not something that has occurred at this moment in time.
Can you speak to, like, in general, how long does it take to set up a medical detox facility?
Well, we were able to move, so in the past, when we were doing isolation and quarantine for the individuals experiencing homelessness, we were able to set that up quite quickly. And we actually had ASP also, or Securitas, which is the same organization that is running the sleep-off center, then provide that care. And then they worked into, but it wasn't full medical detox. There's going to be some additional, if it's truly medical detox, that's some other steps that have previously been taken. So they work with Untitled 2047 to monitor them, but they are not administering medication in the way that typically when someone says medical detox, but that could be just like a vocabulary issue compared to something else. So I'm not 100% sure if they mean it in the strictest sense of the word or like in a general colloquial sense.
Thank you.
And Mr. Constant.
Yeah, I just was gonna add to what you were just saying, that there's not a chance they can set up a medical detox facility in a temporary facility. It's a full-on medical service. And so it would be a social detox program, and it probably is a linguistic issue because you just can't set up randomly a medical crisis center. It goes through all kinds of levels of accreditation and major medical need. So that's a hospital-based or a step down, not quite hospital, but able to do medication and blood draws, skilled nursing. It's a very intensive process.
So across the road is a federal detox center, also attached with the system that does full detox, medical detox. But you could probably throw a football from the planned location of the shelter. If you're a pretty good quarterback, you can toss it and hit that. And plus, you have 2 emergency rooms within short distance.
So I would add
150 feet.
just that Fairbanks has more detox beds than Anchorage, and the volume, the number of beds actually available is the problem at that center, because you can't do more than the beds you have, and they're full, and it's hard to get in. It's not a service that can be just adjunct added to this new proposal, but again, I think it's a linguistic issue. They really have to mean social detox, not bed detox.
Thank you very much.
Yeah.
Ms. Haberman, did you want to speak? Okay, I can give you 3 minutes if I'd like to speak.
My name is Eugene Carl Haberman. I represent myself, follow the public process. When the public process is done appropriately, decision made by the governing body is more like the public interest. First, I'd like to say what I've said in the last couple of meetings in this room, that this is not the place for you to hold a meeting. It's at Dusac Library, where the assembly chambers are, where it's been built for the public to be connecting with you better, and for you to connect better with the public. This is not the place. And if you look right in this room right now, it's filled with more staff, family members in the back, and how many chairs are left for the public. And then the parking space back out there, they're set aside at least 7 spaces for City Hall for assembly members to park and reserve. But remember, this is City Hall building. This is where the public comes during the week for getting assistance. And that limitation by you taking this room and using those spaces interferes with their effort to connect with government and their needs. So with all due respect, you need to move this back where it's placed. Remind you that building in Project 80s was Mayor George Sullivan, the first mayor of Anchorage. That's where it needs to be. Second off is this meeting, respectfully, is difficult to follow. I had to be very close here because most of the meeting, the members of the administration were speaking very softly. So it was very difficult to hear. Also, identifying who's speaking. Respectively in meetings, if those new members of the administration are not familiar, they need to be recognized and need to point out exactly who they are each time so that it's on the record and so the public knows. And note that these are new members of the administration coming in. So it's even more important to connect with who these parties are that are involved in handling the municipality of Anchorage. With all due respect, that leaves 56 seconds to spare.
Thank you. Thank you for your comments. And thank you for joining our meeting. Thank you for your updates. This meeting is adjourned. And we'll take about 5 minutes to reorganize for the next meeting.
This is I'm not sure what magic you pulled, but I didn't realize this was our